Chair, my research is not in euthanasia, but I think I have something to say to add to the discussion. I'd like to thank the Senate for inviting me to speak. I consider this an honor and privilege. These are my own views, do not represent the university or the hospital where I work. I want to focus on one main issue, that of grievous and irremediable medical condition and the understanding of unbearable suffering and what this means for Bill C-7. Someone who wants to die and has a lethal plan, has an active suicidal ideation, is mentally ill. The mental illness in question is almost always a severe depression.
Dr. Hurwitz, sorry to interrupt. I wonder if you can just lift your microphone just a little bit closer to your mouth, please.
How's that? Better?
Perfect. Thank you.
Yeah. Okay. Patients with medical illnesses are suffering and dying. Euthanasia here is a request for a peaceful but premature end. Mentally ill patients are suffering, not dying. They're suicidal to escape severe and chronic psychological suffering. The patient has a clear suicidal plan, a lethal cocktail of medications. They want a serene and dignified death. Such a request is never contemplated in an acute setting. At first presentation, no psychiatrist would ever consider a patient's suicidal ideations understandable, sympathize with the patient, and send the patient on their way to die by their own hands. Worse, no psychiatrist would consider helping the patient implement their wish. The patient is acutely mentally ill. Committal and involuntary treatment should follow if needed to save the patient's life. Beneficence, do good, trumps autonomy, the right to self-determination, every single time. Now, years later, the same patient remains chronically depressed and suffering from an unbearable psychological pain. The only respite from their perspective seems to be death. They believe there's no further help available. The treatment that they want is death. The patient is not in crisis. They present the request as the outcome of well-considered introspection after years of suffering. Suicide is now a treatment, the treatment of choice. But what if we could terminate their psychological pain? In BC, I believe we have the only empiric evidence. This comes from our work with limbic surgery for depression. In 1998, we began to offer brain surgery for treatment-resistant depression, known as bilateral anterior capsulotomy. Here, two neurological cables are severed, one on each side of the brain. The most striking effect of surgery is the rapidity of the effect upon suicidality because of the reduction in sadness. Patients have been ill for years. They have been ill for more than 5 years to be even considered. After surgery, sadness and suicidality vanish instantaneously. I have a video that takes 3.5 minutes. It is in the clerk's hands. If you want to see it, you'll need to ask for more permission, more time. The effect that you'll see is striking and durable. It is worthwhile to reflect what has transpired here. There'd be no changes in the circumstances or medication. The patient's thinking is instantly altered. Very importantly, surgery does not interfere with their computational capacities. Pathological sadness has been taken out of the cognitive equations. Sadness is the very illness itself. It was the cause of suicidal ideation in the acute setting and remains the cause in the chronic setting. To avoid death is normal and rational. To want death is irrational. Rationality is instantly restored when the illness-based sadness is removed. Chronicity is not what is making these patients want euthanasia. The brain illness that was present at the start is still present years later. These patients need protection and treatment, not collusion with the mental illness. The implication of surgery's effect is unequivocal. Depressive illness is a medical disease of the brain, a biological disturbance in a brain network. When pathologically autonomous, as in depressive illness, inexplicable, intense sadness surfaces, pathologically valencing ideas and problem-solving options, such that suicide appears to be the only reasonable solution. Cut the cables, and sadness and suicidal ideation vanish. Limbic surgery highlights two important issues. Firstly, the critical role of emotions in decision-making, and that two, mental illness that drives patients to suicide is not irremediable, not irremediable. Psychiatry has many treatment options. How successful are we In 22 years that I've run this program, only 12 patients in BC have had surgery. We have a population of 5 million people. Our experience has also direct relevance to other causes of severe psychological suffering. There is suffering caused by severe psychosocial privation. Here, the unbearable suffering is better termed demoralization. Demoralization should not be medicalized. We don't treat by medication or offering euthanasia. We advocate for social destigmatization and access to missing supports and services. Demoralization should never be grounds for euthanasia. Patients need relief from their psychosocial privation, not the option of state-sanctioned and provided death. 2, unbearable psychological suffering from severe pain or physical disability. There are many pitfalls here. The case of EF, with which you're familiar, is very illustrative. She had physical disabilities as a manifestation of emotional pain converted into physical pain and physical incapacities, a condition known as conversion disorder. She underwent euthanasia in BC in 2016 without being advised of or given the option of appropriate psychiatric care. Lastly, there are 2 insights from the surgical treatment of treatment-resistant depression. Firstly, unbearable suffering, regardless of cause, distorts thinking and interferes with valid capacity. The future looks hopeless, treatment's worthless, and death the only escape. And 2, in all of these cases, beneficence must again trump patient's autonomy. Thank you for your attention and this opportunity.